Okay, so we're talking about an artificial endothelial lamellar, so-called DMEK lamella here. And I would like to introduce that topic to you. I work together with a lot of companies, also the company that produces this. This is not an approved device, but in studies. So we receive research grants from them. And as you heard, the topic here is I can't wait to get this innovation into my hands. I had it already in my hands, so to say, but we have the very first results. So I like to share with that. And after I showed you some of the results, I will go to these 4 questions, how this has excited me or changed the life. So I think I will do it this way and not answering first the question. So the problem that we're facing is, a couple of years ago it was different, but if I look in Germany at the moment, around 70% of corneal transplants are actually DMEK procedures. Yeah, we're doing rarely, so to say, perforating keratoplasty. There are, of course, indication, but not so often anymore compared to previous times. In Germany, around 8,000 to 10,000 corneal transplants are done. And the funny thing is, over the years, the waiting list has not really become smaller because we have a bigger profile now of patients. So we do surgery earlier in Fuchs endothelial dystrophy. We have patients after phaco that have a decompensated cornea, and the number of patients increases. And the number of patients, for example, for keratoconus decreases because we have other treatment modalities like cross-linking and so on. And so there is still an issue in terms of shortage of implants or transplants. And if we would be able to have an artificial DMEK layer, not a whole artificial cornea, the artificial DMEK, it already would help us. If it's temporarily or permanently, if it will just decrease the thickness of the cornea, and then we can do later a human layer. There are a lot of things we can discuss, and I will first describe you how we use this in the first patients. So what we essentially have here is the product called EndoArt by an Israeli company. There are other doctors from our field involved also in working on this, like Ofne Daphner or Dr. Markovic. And what we actually have is a kind of, looks like a contact lens, which you put inside the cornea instead onside the cornea. It's like 6 millimeter in diameter, dome shaped, as you see it here on the picture. And it's made from contact mark copolymer, hydrophilic acrylic. So that's the same material we use from contact mark for our hydrophilic acrylic intraocular lenses. So it's a material that has been proven over years to be stable, biocompatible. And so there's not really an issue about the type of material we're using here. So the first 2 patients I put it in were kind of desperate patients, and it was not about getting good vision. It was about, can they tolerate it, and do we have a kind of proof of concept? So this patient here, number 1, 58 years, had an externally phaco an IOL implantation years ago, but unfortunately had an endophthalmitis with a postpana vitrectomy with consequent other problems like a corneal decompensation, optic atrophy, then got a DMEK, multiple rebubbling, and at the end she ended up bullous keratopathy, and she didn't want another human transplant or something. But I could talk her into using this because she had a lot of pain because of a bullous keratopathy. You see here the OCT with the 730 micron thick cornea. And I hope this video is running. Is it running? Yeah, somebody is knocking his head. Very good. Thank you, Michael. So we don't had a real regime how to implant this. So I used the conventional IOL inserter and implanted this into the eye, as you can see here. And it comes out in a second. First, what you see is, I think that's just an air bubble. Don't worry, that's not the implant. And now the implant is coming out, unfolding there. And we all know how delicate the human tissue normally is if we have that in the eye. But with this kind of device, you can just touch the lens, so to say, with your spatula like here and position it under the cornea. So something you would never ever do with the DMEK lamella. And then I did this here with the syringe and with the needle. I can directly put some air under it, then position it. And I checked actually here with the intraoperative OCT, and I don't know if you can see here, This is the implant, very nicely already on the inner surface of the endothelium. You can also see this has a little angle here, and you can see that this is the right positioning. If it would be the other way around, it would have been flipped around. So we can see very nicely that we put it on the right place. We also see here the thick epithelium from the long-term bullous epithelial keratopathy. And we don't really think that we need a strong filling of the anterior chamber with gas and air. We did it the same way we did the DMEK, but we have now learned that just the pressurization and keeping it for 10 minutes like this, and then you can remove the air, would be sufficient for enough adhesion. But at this time, we did it this way because we were still learning how to proceed. So I think this is quite clear, and you can see here the implant. Now let's go further. So, oops, that was too fast. So this was pre-op. This was already the very first day, and you already can see that the cornea becomes clearer, especially here in the center. Because of the bad epithelium, I put a contact bandage lens over it. But you see here, nice placement, cornea already down to 593 micron, very first day. So this looks good. Then we went further on. This is after 3 days. After 2 weeks, we had already a normal cornea of around 500 micron, and it stays like this. Now we have 1 year follow-up. We had some issues in between. I had to reposition it. I will talk about that later. But you could already see that this blocks the water from coming in. Let me show you the second patient quickly, which had a similar history, failed phaco, failed DMEK, and also bullous keratopathy, even some scarring here in the epithelium. We did the same surgery. I don't show you the video due to time constraints. Here you can see first day post-op. You see that he had a very bad epithelium also, but already after 1 day, it went down with the thickness of the cornea. We had some repositioning, and we could see that the cornea became thicker after 24 days, but this was done fairly easy, just under, with the syringe. We went in there and the spatula and positioned it, and it was everything we had to do. And here you see after 6 months, a very nice anterior view where you can see that the implant has integrated very nicely. Cornea has normal thickness. Outside the implant, it is a little bit thicker, but here the center is very nice. And just today I saw him for the almost 1 year follow-up, and it's exactly the same picture, so I don't need to show you that. Here you see we had some repositioning, but we ended up in this zone here around 500 micron. And as I said, we did the surgery in June and July last year, and we are now almost at 1 year with very good results. So we had successful implantation and decreased corneal thickness and improvement of clarity. There is an international study going on. Here are the first studies from Israel and Netherlands. They had also 4 implants, which look quite good. And if we look at the average reduction of corneal thickness, we are around like 25%. So here from around 800 to 500 something. But the other cases are not so long on the run. So why does it excite me? Well, because first of all, it works. Yeah, we have we can do that very simple treatment. It's not really complicated surgery. We can do that. It's good material that is biocompatible. Corneal thickness came back to normal. These patients had no pain, irritation anymore. We don't really expect an immunological reaction, not more than we would expect from a hydrophilic intraocular lens. And even if we have some problems, repositioning or other handling is pretty easy to do. It will change the life of the clinicians in terms of that we have an alternative to human tissue. Very easy or not so difficult to learn a surgical procedure. We don't really need a waiting list for that, because if a patient has a corneal decompensation, we can put it in, and maybe even later do a procedure with a human cornea. So this is also quite nice. For the patient, of course, he has also the advantage that he has no immunological reaction. I don't even know if we need, apart from a perioperative steroid treatment, anything more than that. A reduction of corneal edema means no bullous keratopathy, means no pain, no irritation. The costs are lower, less traumatic surgery. I think it can be evenly done in ambulatory day case scenario, but we will see that. And we can also pre-treat a complicated case by decreasing corneal thickness, and then even later do a normal DMEK. It's also possible. So there's a lot of things we can discuss about, and it solves a couple of problems. No human tissue, but with an artificial treatment, we have that. And there are a lot of countries where it is not so easy to access human tissue, like it is in Germany or maybe in the US, where you can just order it from iBanking. If it's a temporary implant or even a long-term implant, we will see. My patients now have 1 year follow-up, and it's still good. So this is very, very good. But maybe on the long run, we can even exchanges, or we can use it with some refractive component. So also correct some refractive error or astigmatism with it. I think there's a lot of potential in that idea. And I'm glad that the basic system is working and that we can see here at least a proof of concept, and the multi-center trial will give us a lot of more insight. So thank you very much, and you can understand, I guess, why I was so excited about this implant.
Thank you so much, Gerd. It was really excellent talk. So at the moment, I have a lot of questions in my mind. I am sure we need very long time to discuss. Very exciting technology, very exciting method. Now, unfortunately, limited time we will discuss after Susan's presentation. Now, okay. Susan Jacob will talk about very nice, very good, very exciting.